Hello, you're listening to Onc Times Talk, the podcast for cancer professionals from Oncology Times. I'm Peter Goodwin, reporting from a rejuvenated American Society of Clinical Oncology 2022 annual meeting. And we're gathering here in Chicago together in person again. And this ASCO started with a bang, with some very lively sessions, including one about new promise for treating brain metastases in patients whose non-small cell lung cancer had already been treated with chemotherapy and immunotherapies. I intercepted the speaker as he left the podium, Alex Spira, medical oncologist with Virginia Cancer Specialists in Fairfax, Virginia. Could you give me a little bit of the background on this? You've got this presentation here at ASCO on adagrasib. This is in advanced and metastatic non-small cell lung cancer. Which category of patients were you looking at and why? And there is another drug in this category, isn't there?
So in the study, we looked at patients with KRAS G12C mutation in the second-line setting, patients that got chemotherapy and immunotherapy. This is a second drug in class. There was a drug approved last year, sotorasib. This is important for a couple of reasons. One is it's proof of concept. For a long time, we didn't have any KRAS drugs. This was deemed the undruggable target. Now we have a second drug that apparently works. Hopefully this will get FDA approval later this year. It's also important because there is some at least preliminary evidence of brain activity, which is super important because a lot of these patients will have brain metastases.
Now, if you have got advanced or metastatic lung cancer, what range of possibilities are there if you have brain mets already?
So the challenges that we have right now is in this population, we don't have anything that really works in the brain very well. We obviously have radiation and those techniques, but we've been spoiled in oncology over the last couple of years with a lot of our drugs having central nervous system activity. And for the first time, we presented some preliminary data today with active untreated metastases. There'll be follow-up data on Monday with untreated metastases. But I think for the first time, we're starting to see some activity and efficacy in central nervous system metastases, which is important because this is a huge unmet need for these patients.
What is it about KRAS inhibition that gives you this activity against central nervous system metastases?
So it's not about the KRAS mutation. These patients do have a tendency to develop brain metastases, but the challenge is getting the drugs into the central nervous system. So how do you get the drugs into the brain? That's the key thing that we've been lacking for a lot of our treatments. It's become a little bit of a almost assumption that a lot of these small molecules do have CNS activity, but that's not necessarily the case. We have to prove it first.
Now, there is already an agent, sotorasib. Tell me about that and why you needed a different one or why you needed an extra one.
So it's always nice to have two, right? I mean, it gives patients opportunities. They do have slightly different side effect profiles. One of the things that people are going to be looking at is, does one work after the other one? Does one work if one is not tolerated? So those studies will be ongoing. It also opens up a lot of possibilities for combination therapy with checkpoint inhibitors and seeing how that is going forward as well.
So can you tell me what you did in the KRYSTAL-1 study?
So the KRYSTAL-1 study didn't randomize. They put 116 patients second line or beyond after chemotherapy and immunotherapy. They all got adagrasib starting at a dose of 600 milligrams twice a day.
And what happened?
So the response rate was 43%. We have preliminary evidence of CNS activity in patients with stable treated brain metastases, and it worked. A lot of patients did require a dose reduction, but most importantly, the discontinuation rate was only about 7%.
Now, how do these figures about progression-free survival and response rate compare with other possibilities for treating pre-treated or already treated non-small cell lung cancer?
So right now in this population, it's what we believe is better. It's not a randomized study, but compared with the standard of care, docetaxel, it appears to be better. Admittedly, it's hard-pressed to see a significant difference on cross-trial comparisons. Of course, we're never supposed to do that, compared with sotorasib. But at least compared with chemotherapy, second-line docetaxel, it appears to be superior, and there's ongoing randomized studies in the second-line setting.
And what sort of adverse events did you see?
Mostly GI. So the biggest side effects are GI-related, diarrhea, nausea.
And how does your new agent, adagrasib, compare with sotorasib?
So again, we're not supposed to do cross-trial comparisons. It's very similar in terms of efficacy. There were a few more dose reductions on our study with adagrasib, but once you got to that dose, most people were able to stay on, and the discontinuation rate was identical.
What might this mean for cancer doctors then treating patients with non-small cell lung cancer?
So we have more options in the second-line setting, and the real goal right now is to move it up. Can you combine it with checkpoint inhibitors? What happens when you give them the front-line setting? And optimizing the doses as well.
Let me take that a little way, if I may, because you had a question about combining with checkpoint inhibitors, and you seem to respond rather positively to that idea, didn't you?
Well, the study's ongoing, right? I mean, there was a question raised today about combination, and of course that study is ongoing. We don't have a lot of firm data right now, but we'll hopefully have some soon. The study is ongoing as we speak.
How hopeful, then, is the situation of following those brain mets and doing something about them with these new agents, do you think?
So I think it's super hopeful. We have preliminary evidence of activity. Again, more information will be presented by my colleague, Dr. Josh Shabari, on Monday, but we have evidence of CNS activity so far, which is super important because, that's a tough area when patients progress.
What would you say is the big take-home message coming out of this work that you've presented here today at ASCO?
So KRAS is clearly no longer an undruggable target. We have 2 drugs, and we just got to get them to more patients. We have to test patients, of course. You can't treat them if you don't test them. But most importantly, how do you combine this and move it up to an earlier line of treatment where patients may do even better?
That was Alex Spira from Virginia Cancer Specialists in Fairfax, Virginia, with the first shot from Onc Times Talk out of this year's ASCO, here once again in Chicago. I'm Peter Goodwin.